Hi everyone, my name is Mary and this is my presentation on mothers' babies who are overlooked in the current drug crisis. The problem I'm focusing on is mothers and babies who are adversely affected by the drug crisis. This is due to gaps in research regarding the effects of substance use on pregnant women and their children, as well as limited access to and knowledge about treatment options. There is less research available on methamphetamine and cocaine, which have seen a rise in popularity recently. Scientists are attempting to create a safe medication-assisted therapy option, but there's an unfortunate stigma surrounding substance use in expecting mothers, which has created distrust of the medical system. And so many won't seek professional help, and because of the fear of embarrassment, judgment, and potential scrutiny from authorities, they might also skip prenatal care altogether. According to a meta-analysis, the mortality rate of infants of drug-dependent mothers was almost 30 for every 1,000 births, compared to about 7 per 1,000 for non-drug-dependent mothers. Teenage pregnant women have the highest rates of illicit drug use at 20.9%, which likely reflects the fact that engaging in risky behaviors, like sexual activity, often coincides with substance use. Black and Latinx women with opioid use disorder are 60 to 75% less likely to receive or consistently use medication to treat their substance abuse during pregnancy. This highlights the ongoing issue of systemic racism and access to culturally competent healthcare. There are lower rates of treatment access for these groups due to lack of health insurance and limited clinics in Black and Latinx neighborhoods. So next, this is an example of what helps and hinders substance use disorder in pregnant women at each level of the social ecological model. At the individual level, individual genetics can have a negative impact on substance use disorder due to predisposition to addiction. Alternatively, if someone is aware of the risks of using substances during pregnancy with proper education, this could stop them from trying it in the first place. At the interpersonal level, cultivating relationships with people who use drugs and alcohol can lead to the development of poor health behaviors because of peer pressure. On the other hand, having a supportive family not only makes it easier to stay away from substance abuse in the first place, it can also pave the way for users to seek help from parents or siblings if necessary. At the organizational level, inadequate screening procedures lead to misdiagnoses of substance abuse. Something that can help at this level is using schools, churches, and rec facilities to spread educational awareness regarding substance use, and that can be done at a young age. Community level, societal norms tend to stigmatize individuals who use drugs rather than offer them support. As a health educator, we have to assist by ensuring that pregnant community members have access to both prenatal care and treatment for their disorder at various clinics without added judgment. The policy level, there are some laws in certain states that consider substance use during pregnancy to be child abuse, which leads to a lot of women missing critical opportunities for intervention. To help this issue, we need to advocate for legislation that protects pregnant women, even if they are users, and increase treatment facility funding. Policies that provide funding for treatment for prenatal substance use are actually linked to a 45% reduction in overdose deaths among pregnant women. So interventions to address this issue. Educational interventions have a strong impact on adolescent attitudes and beliefs surrounding drug use by using videos and lectures as part of regular scheduled curriculum. This must be altered by focusing educational materials on specific risks of substance use related to pregnancy. Peer support groups can also be very beneficial to pregnant and postpartum women suffering from substance use disorder. Women who take part are usually held accountable for attendance and outside treatment. They find a supportive motherhood community, and they have better access to a lot of resources. If there is a language barrier, a translator would be provided to help, and educational materials should be supplied in different languages. Lastly, screening early on for substance use in pregnant women or women trying to conceive is beneficial as well. This can be administered during initial appointments at OBGYN offices, fertility clinics, hospitals, and more. If the intervention is done at a clinic in a different country, we do have to make sure that it's okay with the community stakeholders to continue before beginning. So how to evaluate that these interventions are in fact working? A process measure to evaluate the effects of the educational intervention would be participant feedback, and this can be done by using surveys before and after implementation to assess students' feelings on drug use. A short-term outcome is to increase school-age children's awareness of the risks of drug use. Medium-term, change how students perceive drug use, and then long-term, reduce drug use in adolescents altogether. For the peer support group, a process measure would be taking tests in attendance by using a sign-in sheet at every meeting. A short-term outcome for this is to increase awareness of how substance use disorder affects fetal development and impacts other children and family members as well. A medium-term outcome is to enhance parenting skills, and long-term for the peer support group would be better outcomes for child development. To assess the screening intervention, we would monitor screening rates by pulling records from hospitals and doctors' offices in a form of active surveillance. A short-term outcome for this intervention would be to identify additional pregnant women at risk for substance use. Medium term is to increase the number of pregnant women who receive follow-up care after being deemed a risk from this screening. And then long term would be to enhance ongoing substance use recovery after screening. Of course, there are some challenges and barriers with any intervention. For the educational intervention, schools might resist that the curriculum be taught at all, or there could be language barriers. So to help this, we could share facts and raw data with the schools on why this type of intervention is so effective. Also, we would need to create culturally competent curriculum and keep in mind the possibility of that language barrier when creating the content. For peer support groups, it might be tough to motivate women to continue attending, especially after an initial meeting. So also women might be worried about being judged and might not want to go and be around people that they may not know and talk about their issues. To combat this, we would have to create a safe environment where people are comfortable sharing, even with people that might be strangers, and incentivize them to come by adding refreshments and food at the meetings. For screening, this could potentially be done improperly, and also hospitals might not want to share that data or doctors' offices. So we would have to conduct thorough trainings for providers and whoever's initiating the screening, and then also have patients sign consents for data sharing. We will partner with local schools to deliver the educational curriculum during the school day. We will also partner with community centers so that we have a place to promote and hold the peer support group meetings. And lastly, we will partner with doctors' offices, urgent care, and hospitals in the area to assist with the screening process. This collaboration is essential for fostering a lasting impact within the community. It's vital to create impactful relationships with teachers, school social workers, community center employees, providers, medical assistants, so that all of these operations are able to run smoothly. So my role, if you could guess, is the health educator. Most of my efforts will focus on engaging with school-age children during the educational intervention to discuss the risks associated with drug use. I will also create conversation points for the peer support groups and monitor these discussions during the meetings. My fellow public health nurse will assist in administering the screening tests, while the epidemiologist and researchers will retrieve and analyze screening data from doctors' offices and hospitals. So they will help a lot with that last intervention. So lastly, this is the logic model for this whole issue. And basically, it's just a visual explaining pretty much everything that I just went through so that you can kind of see it laid out all together. All right, so thank you so much for listening, and I hope you enjoyed the presentation.